Tony's already spoken a lot about four-corner fusion and proximal row carpectomy, so much more we need to talk about this, but it's well, indications, Dan.
What's that?
What's that? How do you see that on an X-ray?
After each transition,
So if they had changes in the lunate fossa,
don't see. If they did have changes in the lunate fossa, then I think using
so we've used the lunate capitate hamate and Greek vein plus and minus triquetrum, and you know why we include all those bones. Why don't we just use the lunate decapitate? I alluded to it already. It's just worth thinking about. You don't need it. You don't need a triquetrum. It's really just increase the surface area so that you've got more surface area, and that leads to a higher union rate. Lunate to decapitate. We size the scaphoid for range of motion.
other joints mobile as well, and they can so if you just fuse the capitation of
once you fuse the mid-couple joint, it does increase the stress of the leg. Everything's fine, obviously, but
so there are a number of different ways that you can achieve this. Proximal row carpectomy. So what is it? What's the proximal row carpectomy?
yes.
Sounds fairly clean. Do anything else that, but anyway, it works really well, and you can interpose capsules as well. Yes, you can interpose capsules.
for this procedure, it looks or use the radius to look at everything. Four-corner fusion must preserve.
So the traditional reasons for selection of, how do I get rid of that? The PRC is a simpler procedure, has a greater range of motion and avoids complications that you see with the four-corner fusion, so non-union hardware issues. Whereas the four-corner fusion has postulated you have greater grip strength and lower risk of arthritis progression. So that's what traditionally we say. However, this topic PRC versus four-corner fusion is probably, in some regards, one of the more embarrassing parts of the orthopaedic literature. These procedures have been around for 40 years plus. No level 1 studies, there's no 4 level 3 studies, and there's one meta-analysis which looked at everything else, which is basically level 4 studies. So there's not a lot of conclusive evidence out there, but what do we have? So Mulford, this is really the literature review from the European Journal of Hand Surgery, and this is in 2009, so pretty. And what this found was overall there's no difference in grip strength. The proximal row carpectomy has about 70% of grip strength of the opposite, and four-corner fusion has about 75%. That was not statistically we don't think that that's clinically significant. But both did show an improved range of motion after surgery. So the improved grip strength after surgery. So they had a better grip strength after surgery than they did before, which makes sense. To some degree, they've lost their pain, and that's why we're doing surgery. But there's not much difference between the two procedures. Range of motion, again, no statistical difference between the two. Both overall have an arc range of motion of 76 degrees, which is flexion and extension. Both showed a decrease in that range of motion after surgery. Pain relief, again, there's no significant difference in the pain relief. So what is a good result? It's difficult when you have all studies across all literature to compare what's different, and a lot of studies use a visual analog scale, but at the end of the day, to compare all these studies, you put it into two baskets: good result or a poor result. And the PRC, 84% had a good result, and four-corner fusions, 85% had a good result. So overall, these procedures work, but there's no between the two. Subjective outcomes. How did patients feel? Were they satisfied or were they not satisfied? And overall, the four-corner fusion patients are slightly more satisfied. Was a significant difference. Post-operative complications. So the proximal row carpectomy had a much higher incidence of developing radiographic changes of arthritis. Now that's not painful, wrist, clinically significant arthritis, that's radiographic changes. So how does that affect our clinical outcome? We don't know. However, we know that there's no difference in the rates of conversion from a PRC or a four-corner fusion to total wrist fusion. So we can try and extrapolate from that patients, although they have radiographic changes, are not coming back to us enough for us to offer them total wrist fusion. So in summary, what do you do? Well, do what you do best. Younger patients, you're probably better off with a four-corner fusion because you give them a more durable outcome. You avoid the radiographic changes, at least, of proximal row carpectomy, and it's more anatomical. It's not as much bone left for fusion in the future. So there are lots of reasons to do a four-corner fusion, but you have to take into account the increased complications of painful non-union hardware complications. And so therefore, in an older, less active patient, we may choose a It seems like from the literature that the traditional reasons that we choose one or the other, there's no evidence to back those up. Do you find a difference, Tony, between range of motion in one or the other?